Well, welcome to the 5th annual Heart to Heart with Kadlec, and we're so happy that you could join us today. This is the 5th such event that we have provided here for you and friends and people to get more educated and informed about the importance of heart health. And today our focus is on women and heart disease, but I would like to acknowledge the men who have joined us today. Raise your hands. We appreciate you taking the time to come along with your loved one in support of them becoming more heart healthy. Obviously, today our focus is to increase everyone's awareness of heart health. We have a great program planned for you, including a story from a heart attack survivor and her personal story, as well as some presentations from some of the experts that work at Kadlec in providing life-saving treatment in the cardiac area. I'd like to thank Nick from Charter Communications for videotaping today's program. It will be able to be viewed in the coming weeks on channel 190 for Charter Communications subscribers, and Nick will get us a schedule of that at the appropriate time. But if you have friends or family that aren't able to be here today, we will be rebroadcasting the presentations from our speakers today. Also, our thanks to the folks here at the Red Lion Hotel. They do a wonderful job of assisting our team in organizing today's event and preparing the food that is provided for all of us, and to Simplified Celebrations for the beautiful centerpieces. And stay tuned, you'll have a chance at maybe taking one of those centerpieces home, but we're not going to divulge exactly how that's going to be done quite yet. I'd also like to acknowledge some of the colleague departments within Kadlec that are here today providing educational information for you, and some of the nurses and health experts that we have. Also our friends at the Richland Fire Department, who have not only today but a lot they're all great partners of Kadlec in assisting us in providing educational information, especially relative to the warning signs of heart attack and the importance of acting on that. And so acknowledge our friends from the Richland Fire Department as well. Again, at the conclusion, we have a few door prizes that we will be drawing for, and we'll do that at the end, so hold on to, I think you should all have a ticket. And as we mentioned, we're going to have you hear from 4 people today, and we'll introduce them just quickly now, but we'll give you a little more formal introduction before they come up and speak. But we have Hilda Stewart, who is a heart attack survivor, and we're grateful that she could be with us today. Dr. John Matheson is the Medical Director of Emergency Services at Kadlec Regional Medical Center. Dr. Matheson will be talking a little bit later as well. Dr. Stephen Ewer is a cardiologist with Kadlec Inland Cardiology. I've seen him, I think he's talked to a few of his patients today. But Dr. Ewer is a cardiologist, and he'll be sharing some of his expertise. And Laura Hollister-Meadows, who is a nurse practitioner, an ARNP, which is called an Advanced Registered Nurse Practitioner. And Laura just joined us from the western side of the United States, the western side of Washington, Port Angeles, correct? Port Townsend, I'm sorry, Port Townsend. But she's practicing with Dr. Oro and his practices down here on Columbia Point. So these are our 4 speakers, and at the end, I'll just ask you as well, at the end, when they're all done speaking, we're going to also open it up for you if you have any questions. So be thinking of questions you may want to ask, but we're going to wait and do that all as a panel when each of the speakers is done talking. So let's give an advance round of applause for our speakers. But before we introduce Hilda's going to be our first speaker, we prepared a short little video that outlines the scope of cardiac services that we have here at Kadlec, and we'd like to play that for you now.
Heart-related services at Kadlec are comprehensive. Whether a patient has a chronic condition like a heart valve defect, congestive heart failure, or an acute heart attack, Kadlec is here providing the full spectrum of cardiac care. The team is deep. It includes first responders, primary care providers, the emergency department, diagnostic imaging, heart catheterization, cardiac surgeons, nutrition counseling, cardiology, and cardiopulmonary rehabilitation. Coordination is vital. When a patient suffers a heart attack, time is crucial in getting the needed treatment. Often, skilled paramedics are first to respond. They have the ability to begin treatment immediately and send critical information to the Kadlec Emergency Department. As a result, if the patient requires urgent cardiac intervention, The team is ready when the patient arrives at the ER. Kadlec holds the distinction as a Level 1 certified chest pain center for all cardiac-related care. The team is able to immediately open arteries with stents and balloon angioplasty, and the only hospital in the area to perform open heart surgery. In fact, Kadlec's heart program was the first in the Northwest to earn this distinction as a chest pain center. Physicians are key to the team. Kadlec Clinic provides the community experts in diagnostic and interventional cardiology, cardiothoracic surgery, and electrophysiology. EP cardiology, as it's called, is an expanded service at Kadlec, allowing patients to stay home now for this specialized level of heart care, such as heart rhythm issues and placement of defibrillators. What happens after major surgery, an angioplasty, or stent? It is highly recommended patients participate in cardiac rehabilitation. This is a multi-week program offered at the new Kadlec Healthplex, where patients work with trained nurses and fitness specialists to finish the final leg of the cardiac journey. All along the way, Kadlec offers concentrated education and counseling, whether it's nutrition, CPR, diabetes, a full scope of services to keep all of us heart healthy. So if the symptoms of heart attack strike, call 911 and take comfort in knowing an expert team of caregivers is ready to serve.
So that summarizes the scope of services that we have at Kadlec. And interestingly, we draw patients from not only the Tri-Cities area, but if you drew about an 80-mile circle around the Tri-Cities, that would roughly define where patients come to Kadlec for specialty services such as cardiac. So places like Pendleton and Hermiston and Walla Walla and Milton Freewater, even as far away as La Grande and Baker City. So it really shows, and I guess it magnifies what you'll hear is the importance of acting on symptoms, because you need to get to the hospital right away so that these guys right here can take care of you. And who better to share that message as our first speaker today, and that's Hilda Stewart. Hilda is a third grade teacher in the Kennewick School District, and she has been teaching for 29 years. And she has an incredible story to tell, and we're so thrilled that she would take the time to share her story with all of us today. So please join me in welcoming Hilda Stewart.
Gee, thank you. I guess I'll start out with January 28th of last year. My life totally took a nosedive. Just a little bit of my health issues. I have asthma. There's heart disease in my family. My mother, brother, and sister have all three had heart attacks, 2 with stents. One had cardiac arrest and was saved just in the nick of time. I have a good cholesterol, but bad cholesterol. So I've taken Lipitor for several years. I had been sick with bronchitis 2 weeks prior to my heart attack, so a lot of the symptoms I experienced, I attributed to my bronchitis or my asthma. On January 28th, I got out of bed and just felt like I had been out partying the night before. I was dragging and fatigued, and just getting through the shower was a real ordeal for me, and I knew I just didn't feel right. I wasn't my 100%. I usually play music, dance in the shower, or, sing, and it was just tough getting through that shower. Made it to school at 7:30, and as the day wore off, there was a tightness in my chest, and I said, well, gee, my asthma must be really bad. I'd get my inhaler and take a couple puffs and feel okay for a little while, and then, geez, it just keeps getting worse. And as the day progressed, the tightness got tighter. I felt real fatigued, and it was just not feeling like myself. I know my body, and I know when I'm sick. When you're getting the flu or you get chills or something, but that day was just totally, totally different. But I just kept putting it off, thinking, well, it's my asthma. Oh, I had bronchitis 2 weeks ago, so, I'm just not over it. I have an asthma appointment with my doctor this afternoon at 4 o'clock. I'll make it till then. So, and as a teacher, you never want to call in a sub after lunch because you're not going to get one. So I'll do it, And anyway, I can get through this. Kids went out to recess at 1:45, and I tried to walk to the office, but I maybe made it to the next classroom and stopped. I was out of breath. I couldn't breathe. I was having trouble breathing, and then I was feeling these little aches in my arms, and I said, oh, it must be that new Lipitor because they upped my medication. I'm getting pains in my joints and my arms and wrists. So I walked back to class, and my kids know me, and they take really good care of me. When I'm sick, they baby me. They're just wonderful. And I said, kids, I'm going to have you just read right now because Mrs. Stewart just does not feel good. And they took their books out, and did you take your medication today? Did you take your medication? Yes, I did. I took my medication. Do you need your inhaler? I'm fine. I already took my inhaler. So they're reading, working quietly, and 2:40, I looked up at the clock, and I got the most excruciating pain in my chest, right in the middle of my chest. It was so bad, my head dropped to the table. I did not want my kids to see me in pain, but I got through it. My arms were hurting, and I just turned around and got on the phone, called my asthma doctor's office, and I said, hey, I'm having some really bad chest pains. I'm having trouble breathing. Is there any way you guys could take me in right after school instead of 4 o'clock? And they said, you come in as soon as you can. So I emailed my principal and said, I'm feeling really, really bad, and I need to get to my doctor's right after school. Do you mind if I just leave with the kids? She emails back, sure, that's fine. And then she emailed again and said, do you need me to take you right now? And I said, yes, I need to go right now. So we calmly got the kids quietly getting ready to go home, so another teacher came in and took over my class. She drove me to my doctor's office, which was just down the street. Luckily, I walked in and I told her, you can leave. I'll call my daughter. She'll come get me. Or I'll call my husband. He'll come get me. And she left me. There was one patient in there, and luckily that patient was only waiting to get her allergy shot checked, so they took me right in. I wasn't in there very long. My doctor says, Hilda, I don't think this is your asthma. I think this is more than I can handle here. You really need to go to ER. And I said, well, there's nobody to take me. And she goes, well, we can call the paramedics. Oh, no. I don't think I need that. I really think it's heartburn. My husband made a pot of cowboy beans the night before, and I had a little bit of beans, and I think it's heartburn. Anyway, we're still talking and back and forth, and by then the paramedics are coming in. They took my blood pressure, and off we went. I'm still arguing with them in the ambulance going, you know, you guys, it's just heartburn. I know it's just heartburn, or it's my asthma. I was sick a couple weeks ago, and it's just that. And they go, no, Mrs. Stewart, we think you've had a heart attack. So they gave me the nitroglycerin, the 5 baby aspirins, and I'm still thinking, you got to be kidding me. Not me. Not me. I go to my daughter's gym. She has a 24-hour women's fitness gym that I go to. I thought I was eating good, taking all my medication. It just wasn't supposed to happen. Anyway, they're telling me just calm down. So I'm on the phone trying to call one of them to come pick me up at the hospital or meet me there, and nobody answers the phone. Made it to Kadlec, and they instantly, as soon as the doors open, I'm still in awe at how quick everything was done. I was taken to a room. There was an attending physician waiting for me. They did a test that was so quick that they knew I'd had a heart attack. And from there, they took me to the cath lab. They did what they had to do, and the Dr. Jamali says, you know, I've got good news and bad news. Which one do you want first? And I said, well, give me the bad news. And he says, you have had a heart attack sometime today. Good news is the heart muscle was not damaged. So I'm just okay, I guess that's good. I don't know. I go, well, can you fix me up? And he says, that's another bad news. We can't fix it with a stent. I can't fix it here. You have 3 arteries that are clogged, and one is hard to get to. It's underneath the heart or something like that. And I go, well, how do you fix those? He says, you'll have to have open heart surgery. And that's when I, really? What do you mean open heart surgery? And he says, you need to have a triple bypass. So I'm like, okay. He says, I'll explain it more when I talk to you and your family. And it wasn't until the family was all around my bed, and he's explaining all this about the heart and the veins and harvesting veins and doing all of this and that. And I'm like, you gotta be kidding me, not me. I mean, it just didn't seem possible. And within 12 hours, I believe, I was in surgery and had a triple bypass that lasted 4.5 hours. Everything, luckily, came out okay. I feel great. I was in the hospital for 5 days and got to go home on Super Bowl Sunday. Of course, I don't remember much of that. 8 weeks later, I was in cardiac rehab, and I was nervous about that because I was afraid I'd have another heart attack. They wanted me on treadmills, on the bikes, and doing, I don't know what they were going to do to me. I was kind of nervous. But the first day I went in there, they talked to me, they evaluated me, they hooked me up, and they kept track of my heartbeat on their monitors, and it was okay. I only ended up going 9 visits total time because they were making me stop and slow down on the machines because I was going too fast and my heart rate was going up too fast. So anyway, after that, I went back to work after 12 weeks, finished out the year with the kids, and I go to my appointments, and if anything is wrong, I call my cardiologist's office, and they say, come in, we'll get you checked out, just so you're sure of everything's okay, and so far, so good. I'm just so thankful to everything that Kadlec did for me and how quickly everything was done, and the expertise of the doctors, the surgeons, the nurses, everyone that was there to help me. If I had not gone and called my asthma doctor and gone home and waited till 4 o'clock, I wouldn't be here today. But I'm grateful to everyone that was involved and helped me through this, and especially Kadlec. So, thank you.
Is she a natural speaker or what? That's an awesome story. Thank you so much for sharing today, Hilda. We'll just kind of leave. There we go. I think that is a reminder to all of us that we act on those symptoms. And I was going to say, it was last year's Super Bowl that she got to watch, the win. If she would have been in that situation, that last play may not have come. She was telling me, yeah, that was last year's Super Bowl, Jim. Well, our next speaker is Dr. John Matheson, and he is in charge of the emergency departments at Kadlec Regional Medical Center, both the emergency department here in Richland and the freestanding ER in Kennewick. He's board certified in emergency room medicine. He's been the chair and medical director of the Kadlec Emergency Department since 2006. He's residency trained in ER medicine, and he is currently the president-elect of the Washington chapter of the American College of Emergency Physicians. John is married for the past 22 years and has 5 children. And he's a shadow of his former self because he is a tall man, but he is a testament to the importance of living a healthy life. And Dr. Matheson is a great ambassador for Kadlec and a great ambassador for educating folks on the importance of things like living heart-healthy lives. Please join me in welcoming Dr. John Matheson.
Well, thank you, and it is an honor to have been invited to speak with you today, and thank you for sharing your story. I think that personal experiences, personal stories like that are far more impactful and meaningful than anything I'm going to share. So I'll sit down now. I did confer a little bit with Dr. Ewer as we were talking about what we were going to say. Realized we may overlap a little bit, and I was concerned until I found out I was speaking first. But he gets to correct everything, apparently. We are talking about women and heart health, and I think I would be negligent if I didn't acknowledge some very important women in my life. I'm grateful to have had a very strong mother who taught me about caring and compassion and service. She, too, was a teacher for many, many years and instilled in her children the importance of education, and I think that her influence had a large role in my pursuing medicine for the human side of it and also the learning side of it, and I'm grateful to her for that. My wife Angie, who tomorrow will be our 23rd Valentine's Day, is my Valentine, and grateful that she's still my sweetheart. And I'm fortunate I have 5 children and 2 wonderful young women, daughters, and it's fun to see them grow, develop. They're becoming interesting, talented, great young women, and I'm excited to see what they will do with their lives and how they're going to shape this world. So as we're talking about women's heart health, of course, it's natural to want to look at what are some of the differences in how women present when they're having heart problems compared with men. I'm in the emergency department, so I thought talking about presentation of heart disease and how it looks when having it. And I think what we learned here really echoes some of the comments. And what I want the take-home points to be are, number one, there are some differences. Findings can be subtle. The symptoms can be subtle. Don't ignore them. Don't ignore even those vague, non-specific symptoms. They are important, they are real, and ignoring them can be devastating. And last, advocate for yourself. And we'll talk about that a little bit as well. So, how are men and women different? Well, we're not going to get into Venus and Mars. But first, when it comes to heart disease and heart health, first thing, there are differences, but there are far more similarities than there are differences. Women, when they present with heart disease, though, tend to be older than their male counterparts. That doesn't mean young people don't get heart disease. I've taken care of too many women in their 30s who are having heart attacks. It's not common, but it happens. But there appears to be, or there is some protective nature that goes in women before menopause. After menopause, though, I'm afraid that you catch up very quickly. We know heart disease kills more women and affects more women than breast cancer, ovarian cancer, or all the cancers combined. It is real and it does happen. Women aged 45 to 64, about 1 in 9 will have symptoms of heart disease. After 65, about 1 in 3 will have those symptoms. Now, when they do present, women tend to have a more subtle presentation. They may not have the classic horrible chest pain. But when somebody's out shoveling snow, not this year because we don't have any, but when somebody's out shoveling snow and they get that crushing pain and they say, oh, it feels like an elephant on my chest, and by the way, it hurts up in my jaw, my left arm, and I'm sweating and I can't breathe, and I've got diabetes and high blood pressure and high cholesterol, and everybody in my family has had heart disease. That's pretty easy. I can figure that one out usually. But it doesn't always present that way. In fact, women are more likely than men to present having a heart attack or severe heart disease without chest pain. It may be that it's just feel really tired. Every time I get up, I feel kind of winded. Just don't feel myself today. I have that stomach ache. I have that cowboy chili, or whatever they, you know. And not long ago, I took care of a woman who came in because she just didn't feel right and she couldn't stop burping. She was having a heart attack. It happens. So they can be much more subtle. Now, on the other side, women are more likely to have some symptoms before they have their heart attack. They're just more subtle. And speaking of the subtle, my wife would probably say women just don't whine as much as men do. And that's probably true, but women are more likely than their male counterparts to have symptoms leading up to the heart attack, where men may present with the heart attack the first time. And again, as we've seen, women will often present that first time with the heart attack. So now we have this challenge. We've got more likely to have those symptoms, but harder to recognize, more likely to dismiss them, more subtle. And unfortunately, too many patients themselves dismiss the symptoms, and I'm sad to say, too often the medical community is guilty of dismissing some of those symptoms as well. And that's where what I said before about being an advocate. None of us wants to admit we're ill. None of us wants to call these guys to come and pick us up and take us to the hospital, and we can think of every reason in the world not to and try and explain it away. My wife was a good example of that. My very first case that I diagnosed appendicitis was my third year of medical school, and it was my wife. And she was lying down, couldn't get up, and kept saying, "It's going to go away, it's going to go away, it's going to go away." I told her, yes, it would when they threw it in the bucket. And it did. But none of us wants to call the ambulance and make the fuss and have them come and then find out, oh, it was indigestion or something. But your heart is important. You only get one of them. And if you can find the problem and take care of it before the damage is done, before that heart muscle is lost, you can go back to living a healthy, active, good life. So be an advocate. And again, recognizing that you may find resistance even among medical professionals that, oh, that doesn't sound like your heart. You know yourself. If it's not right, speak up, be an advocate. Thank you for letting me share with you today. This is a great event, and I hope to see you at more events like this and not in my emergency department. But if you do need it, please don't hesitate to come and see us. Thank you.
Thank you, Dr. Matheson. Is there a theme running so far that we're hearing is act and advocate? I think that really rings true for everybody. Our next speaker is Laura Hollister-Meadows. As we touched on, she is what's called an advanced registered nurse practitioner. And she is a relative newcomer to the Tri-Cities. She came here from Port Townsend and is practicing with Dr. Joseph Oro down here at Columbia Point, so just down here next to the golf course, not far away. Laura's care philosophy is to be open and honest with her patients while serving as an advocate for their medical needs. She has training in cardiology and extensive experience working with patients living with hypertension, cardiopulmonary disease, and diabetes. And she's a member of the American Academy of Nurse Practitioners and board certified in family medicine. So I'd like to welcome to the Tri-Cities and welcome to our event, Laura Hollister-Meadows.
Thank you for having me. I'm delighted to have been asked to speak here today to all of you, and hope to get to meet more of you afterward. I am new to the Tri-Cities. A couple things I learned as I was listening to the two speakers before me. One is I should probably mention that I've been practicing for 10 years and that I didn't just come out of high school graduation to show up today and share a few words on what I think exercise is about. But the other thing that really moved me today was listening to Hilda's story about her survival. And About 5 years ago, when I was practicing in Port Townsend, they asked me if I would help them develop a cardiology program at that facility because we had no cardiology on staff, and cardiology services was a minimum of 50-minute drive each way. So building that program in that community really meant a lot to me, and it meant a lot to me in a professional way, but also on a personal level. And I personally lost my aunt 3 years ago to a heart attack, and very much like you, Hilda, it was really touching in terms of her, your energy level, your physique, how active you are. That was her story, and she didn't tell anyone. So, anyways, I would say, today my presentation is more on how do we prevent you from getting to that point. But again, I just want to echo all of the other comments that have been made up till now about really listen to your body and please be safe. Don't be sorry. Just come forward and say something's not right, and make sure you're communicating that as best as you can. So anyway, I wanted to talk a little bit today about exercise because I knew that my physician colleagues were probably going to be talking to you a little more about how symptoms present themselves and how to act on them. And so I figured I wouldn't get roughed up if I talked about exercise and stayed out of that arena. So one of the things that, as I was looking at information about exercise, I think there are three main approaches to it: steps, or how many minutes, or how hard should I be working, calories burned, miles run, all that other stuff. And so what I wanted to talk to you about today is how to combine all of those in a meaningful way for you. And so I think what's important is that as you look to sort of reassess yourself and where you are in your exercise, is you ask, what's my goal? Is my goal to be, have better cardiac fitness so that I am doing activity that helps promote a healthy heart? I don't want to overdo it because maybe I have problems with rheumatoid arthritis, or I haven't seen the doctor in X many years, and I want to be careful about how I do all of this. But I do want to start getting active. And so in that regard, steps are going to be more meaningful. If you're saying, geez, I walk pretty regularly, I've been active, I take my medicine, and I see the doctor regularly, I think there's a way for me to improve more. How do I exercise in a meaningful way? Then we're going to look more at, how vigorous is your exercise and how often are you doing it? And I think, then to move on to a third goal, if your goal is, gosh, I'd really like to lose 15 pounds because Dr. Ewer told me if I lost 15 pounds, maybe I won't have to take my blood pressure medicine anymore. And so helping to set those goals for weight loss. So this slide first highlights about how steps have shown significance in decreasing occurrence of adverse events, and particularly with heart events. And so a study that was recently published by the journal Lancet did show that even walking an extra 2,000 steps per day is significant in lowering your risks for cardiovascular events. This is in the setting of adding to what you're already currently doing. And what they say is, for a sedentary individual, this is somebody who's not out walking the dog or parking at the other side of the parking lot and walking to work, but somebody who's basically just doing household activities, you're probably only getting about 3,000 steps per day. So if I walk 2,000 steps, what does that really mean in terms of actual activity? You're adding basically a mile each day to what you walk in your normal activity levels. So it kind of just gives you a little bit of an idea from that perspective. I like this slide. I found this published in one of the articles that I was reviewing. It sort of highlights number of steps versus obesity rates. And in this particular study, it showed that average steps by Americans was around 5,000. And I think it was a younger adult group, 40 to 60, but active in terms of being out there and doing some amount of small activity. So they're not considered totally sedentary, but still, even in that setting, look at where we compare to other countries, Japan, Switzerland, and Australia. So, and showing you that the correlation of more steps taken is a lower obesity rate. This I found, in whether or not these are evidence-based, I cannot attest to that, but I thought they were kind of interesting because, you know, it's easy for us to pop a brownie bite or the cupcake that's in the back break room and say, I'll walk it off later. But I thought these were pretty phenomenal in terms of the findings here. So on average, a person would need to walk 7 hours off to burn off a supersized Coke, fries, and Big Mac. So if you're planning on doing the drive-through, you should probably plan on walking to, Prosser and back maybe. 150-pound woman would have to walk 4 miles an hour for 48 minutes to burn off a 240-calorie donut. This would be equivalent to just over 3 miles. And this is my favorite one. This was the most depressing one for myself and Dr. Oro. To burn off one plain M&M candy, a person would need to walk the entire length of a football field. So now, I don't want to rain on your parade. I don't want to be like, come on, seriously, who goes without M&Ms? But I think what this highlights is that we have to strike a balance. So if you're going to eat it, enjoy it, but plan on making sure you're busy later in the day to burn off what you've eaten. When we ask, okay, well, I'm trying to set myself some goals in terms of weight loss, as you saw, just by increasing your steps by 2,000 steps per day, you're going to get a cardiovascular reward from that. Dr. Tudor-Locke, she is someone who has done an astronomical amount of research in exercise and diet weight loss. And so as she looked at her years of research as well as other people's studies, her recommendation that she came up with was that if you want to be staying active in good cardiovascular health, your goal for step counts would be 8,900 to 9,900 a day, with 3,000 steps being in moderate to vigorous intensity. And so this sort of segues into the next part of my presentation here, because we want to talk about, well, what does it mean to be, to have moderate or vigorous activity? And so the CDC says, look, we're going to help you come up with this fancy little math equation on how you could objectively identify when you're working moderately or in a vigorous setting. And so, and we use this in the medicine world as well, especially if we're doing cardiovascular stress testing and stuff like that. So this is something that we're using as professionals. But so if you wanted to find out, okay, how high do I need to get my heart rate? You take the number 220 and you subtract your age from that. And you want to aim to that number, that 220 minus your age, that tells us what your maximum heart rate is. And so what your activity level, if you're working moderate in intensity, is going to be anywhere between 50 and 70% of that value. This is percentages if you were trying to get to more advanced cardiac fitness and weight loss. This is what is classified as a vigorous intensity, and that then percentage changes from 70 to 85%. Just a quick review on what it is when you're trying to measure your blood pressure, your heart rate. You can check along your neck or putting your hand over your heart. You can try it that way, but the most reliable way is to assess your pulse at your wrist. And one of the things I love for nursing school is I remember a professor saying, it's not a piece of furniture, you don't need to push that hard. So when you are checking the pulse rate, make sure you do so lightly and count for a full 60 seconds if you can, if not 30, and then multiply it by 2. But that's how CDC recommends checking your heart rate. So in terms of activity for duration of activity each week, they're saying 2.5 hours of moderate intensity aerobic exercise, and then 2 days a week of muscle weight training, and to try to do all major muscle groups, including legs, hip, back, abdomen, chest, shoulder, and arms. So you're looking at about 30 minutes 5 times a week. This is my favorite slide. I love this slide because look at her face. Okay, so I think it's wonderful that we can do these percentages and math equations, and I'm a math junkie, so I'm good with it, but not everybody, that's not the way they roll. So I like this because this part of the presentation is going to highlight how your level or perception of exertion is just as telling as a measurement of a heart rate. And I like this face. Because girlfriend at like 8 and 9, she's not telling you what happened last night and why her husband, she got a fight over dinner. she's all she's thinking about is, getting her next breath. That is vigorous exercise. According to the CDC, most people, light daily activities such as shopping, cooking, and doing laundry don't get your heart rate up enough and should not count toward the exercise guidelines. This, I think, is important to remember because people will say, well, gosh, I'm at work and I'm up and down, I'm walking to the copier, and then I'm over here and I'm faxing that and all this other stuff. And while it's good that you're getting the activity, it doesn't get your heart rate up, and it doesn't count toward these recommendations for good cardiovascular training. So if you're at a moderate intensity, remember the picture of Our Lady, you're at a 5 or 6, you probably can still talk, so you can have conversation, but you're not going to be singing, your favorite song or having really deep and pensive thoughts on world politics, religion, etc. So it's going to be brief conversation, and I think that's how you know how hard you're working and if you're getting your heart rate up. How many times do you need to do this during the week? You need to try to aim to do this at least 20 minutes and 30 minutes 5 times a week. That's your 3,000 steps daily. 3,000 steps. I can talk, but I'm not singing. When you talk about vigorous exercise, looking at an intensity level of 7 or 8, working at this level means that you'll be able to say a few words, but you're going to have to pause to take a breath. You're working, you're running. The lady's got a red face. She's huffing and puffing. And so that's when you know that you're at a vigorous intensity. And this is going to put you at those percentage rates of 70 to 85% that we talked about earlier in terms of measurement of heart rate. So I think what I really hope that people will glean out of this is that when you first talk about exercise, ask yourself, what is your goal? And the thing is that if you're new to exercise or you're just starting to get back into things, start slow. Say, my goal is going to be 2,000 steps a day. I'm going to add 2,000 steps a day. That's my goal. And then you can start to move yourself through this process of moderate and then maybe one day vigorous. But being active, doing something makes a difference. Don't say, well, I can't walk 10,000 steps a day, so what difference can it make? Well, as we've seen, even 2,000 steps can make a difference. So anyways, get out there and get busy. And if anybody wants a copy of these slides, I'd be more than happy to share them. I know there's a lot of information on them. So thank you.
$2,000? Wow. Our final speaker this afternoon is Dr. Stephen Ewer, and he is a cardiologist with Kadlec Clinic Inland Cardiology. Their office, by the way, located at 1100 Goethals. It's the 1100 building over off just east of the emergency department. And Dr. Ewer has practiced cardiology in the Tri-Cities since 1996. He is currently a member of the board of Kadlec Clinic. He's a fellow with the American College of Physicians, the American College of Cardiology, and the American Society of Nuclear Cardiology. And we're thrilled that he is going to share some of his time with us today. The cardiologists here in the Tri-Cities are all extremely busy. All of these physicians and all these practitioners, amazingly, are very busy people, and we really appreciate them taking time to share their wisdom with all of us. So please welcome Dr. Stephen Ewer.
Thank you for having me. First thing I'd like to say is Happy Valentine's Day to everyone in the room. I proposed to my wife on Valentine's Day 1989. Long time ago. We just had our 25th anniversary mid last year. I was on call, and 5 minutes after that proposal, my pager went off, and I was out the door. So as I was walking out the door, I asked her to start planning. I'd like to thank the other three speakers here. They're excellent presentations. And thank you for making my job easier today, because a lot of what I was going to say has been said. And yeah, I think you said it in ways probably better than I could. I want to talk a little bit about the challenges that we face in dealing with women and heart disease. There are a lot of issues with women that make heart disease much more difficult and complex. So we have lots and lots of challenges going forward, both in clinical practices, but also among researchers and people, the thought leaders in universities who study prevention and epidemiology and things like that. So I'm going to summarize some things, summarize a little bit of what Dr. Matheson has talked about, and then you'll kind of have a sense as to why we even have conversations like this in big forums about women and heart disease. Cardiovascular disease is still the most common cause of death and disability in the United States. Male gender is a major risk factor, and it's not a major risk factor actually to be a female. Major risk factors being smoking and diabetes, high blood pressure, cholesterol, family history, and being male. However, 1 in 9 women between the ages of 45 and 65 develop symptoms of cardiovascular disease, and a third of women after the age of 65. There are important differences between men and women in their presentation of heart disease. As Dr. Matheson had pointed out, symptoms are not always the same. Many women who are having heart attacks don't actually have chest pain. Women present on average 10 years later than men, and that's usually because they have more risk factors. Women are less likely to have typical symptoms: shortness of breath, chest pain, sweating, nausea, exercise-related symptoms. And then women sometimes describe symptoms differently. Sometimes chest pain is mistaken for fatigue. Fatigue can be described as chest pain. Women, and as Dr. Matheson has mentioned, women having heart attacks are less likely to actually have chest pain. Sometimes making that diagnosis is more difficult. Heart attack symptoms among women are often unrecognized, both among family members and caregivers, especially in young women or women with diabetes. And for reasons not entirely clear, women tend to be less aggressively evaluated for chest pain. When it comes to testing women, stress testing is often inaccurate, and we have to do other sorts of testing to look for evidence of underlying coronary artery disease. And for reasons not entirely clear, women are often less likely to be referred for more advanced testing after having a positive stress test. When it comes to treatment and outcome, women have a higher incidence of heart attack and dying, and women tend to not do as well with revascularization. Women are also more likely to develop complications of coronary artery disease, such as congestive heart failure and heart rhythm problems. Again, things that we don't completely understand. And overall, women die more often from coronary artery disease, in large part because women tend to live longer than men. So these are some of the challenges that we face when we talk about women and heart disease. I think a big part of the solution is what Dr. Matheson had alluded to, and that is being your own best advocate. And that means, in part, working in partnership with your caregiver on risk factor management, good communication about symptoms, and dealing with exercise, as Laura's talked about, diet, et cetera. And I think that between patients and caregivers, that we can go a long way to overcoming a lot of these challenges that we face going forward. Thank you.
Thank you, Dr. Ewer, and thanks to all of our panelists. We're going to now open it up to all of you. We have one ground rule. When you have a question, you have to wait till the microphone gets to you, because Nick is going to broadcast this, and everybody wants to be able to hear your question on the microphone. So Emily is going to take the microphone to you right there in the back, who is standing waiting to ask a question. But please wait till you get to the microphone if you have a question. And we have about 15 minutes, actually, where we can entertain any questions that you might have. So just shoot your hand up. Emily will find you. And if you would, you can state your question to one particular panelist, or if you want to just ask it to any of them, they can have a free-for-all to determine who wants to answer it. So go ahead, ma'am.
I'll start with
Dr. Ewer answer it.
Jim, as the spokesperson for Kadlec. I'll start with you, and then these gentlemen over here from Richland Fire Department. Both my husband and I had occasion to be guests of Kadlec and Richland. Unlike Hilda, who showed a kind of courage I can't even imagine, we wimped out and called 911. We both thought we were having heart attacks, a variety of reasons. We're lucky, again, nothing like what Hilda experienced. But when people say world-class, Kadlec and Richland truly exemplify that. We felt so cared for. We were in there so fast. Everything just sort of, it was just amazing. We got to spend the night there, too. Dr. Matheson's point, I used to weigh 263 pounds.
Oh my goodness.
And that's not really very interesting. What is interesting, I think, is each of the panelists brought forth something. We're meant to thrive in our lives, not give in. We don't need to have, and sorry, Bill always tells me I don't practice medicine. I'm not equipped to say how to lose the weight. I did mine by keeping my mouth shut and starting to walk. And this little Fitbit, which I see, it's a good shout out for Fitbit, get one. This has told me that I've walked 3,000 steps, so yike. I've used a whopping 800 calories, so it's a good thing I haven't started on the M&Ms yet. But measure it. I'm in better shape at 62, and again, this isn't particularly interesting, than I was at 32. I don't want to die at Kadlec. I love it there. I'd rather volunteer there than die there.
Thank you for those comments. Yes, go ahead.
Thank you for taking our questions. Dr. Ewer, I have been reading about, not reading enough about it, I can't find more information, the LP plaque test. How accurate is it? How available is it? And can you tell us something else about it, especially for women? Thank you.
Yeah, that's a good question. The LP plaque test is actually a new test that is a blood draw, and it's used for looking for signs of inflammation. It's another inflammation type test. I don't know that it's available in the Tri-Cities yet, but it's becoming more mainstream. And when I'm able to order it, I'm going to start ordering it on probably everybody.
Next question over toward the middle of our room.
Yes, I have a question. Years ago, I heard this on TV that taking it was a male, but still, I wonder if he knew that he had the symptoms of the heart attack, and so they said that he had chewed the aspirin before anybody arrived to take him to the hospital, and that saved his life. Now, is that still a good thing for us to do, or is it just hindering? Would it hinder to take the aspirin to help maybe stop it? Or
If you think you're having a heart attack, aspirin is a very good thing. That's the first thing that we do in the emergency department. Plain old aspirin is still one of the best medications. Now, don't take an aspirin and then say, I'll go lie down and see if it goes away. That's not the message. Take the aspirin. It does help, because when you're having a heart attack, when one has a heart attack, the coronary artery, or one of the vessels feeding the heart, usually have a buildup of plaque. It's not that gradual buildup of the cholesterol and plaque and so forth that causes the heart attack. You'll have that narrowing, but what happens is you'll get a clot, an acute clot that then fills that in. Aspirin is a mild blood thinner. It prevents, to some extent, that clot formation, and so it does protect. It does not keep us from being able to do the stenting and the surgery and so forth. There are some concerns with some of the other blood thinners. But yes, aspirin is a good thing, and that should be one of the things. You don't delay calling these guys to take your aspirin, but take your aspirin. And if you haven't, they'll bring it with them into your room and give it to you before they leave your home.
Aspirin, by many measures, is one of the most important drugs we have in cardiology. It's easy to take, it's well tolerated, and we know it works. Chew it. Yeah.
It'll be absorbed a little faster.
And it would be a single aspirin, in what dose?
Generally, if you have baby aspirin, the people use it because it is chewable and it's designed to be chewed. But a full aspirin, 325 milligrams, or 4 baby aspirin is often what we do. You probably get the benefit with about half that, but 1 full is adequate, and that's not a lot. People, if they're taking it for their headache, usually take a couple of them. So,
I agree. Yeah.
Emily, right over here right in front of Nick, I think. And then we'll.
If you're on Coumadin, would you still take a baby aspirin under those circumstances?
If you are having a heart attack or think you're having a heart attack, a single dose would be appropriate. It does increase your risk of bleeding, but at this moment we're worried about that clot. And so if you're in my emergency department and you're on Coumadin, I'm going to give you a dose of aspirin.
Yeah, I have a couple of questions. The first one is, I know that you have probably the best cardiac department up there, but what type of insurance? I've heard that there's certain insurance program that you can only be either to be in Trios or Kadlec. What do you guys take?
I honestly don't know, because I don't even look when somebody comes in the emergency. It doesn't affect whether I treat them or not. I don't know. Each insurance is going to be different. I'm not the one to answer that. I don't.
Unfortunately, I don't know either. I'm looking at the patient and the problem and trying to solve it.
My understanding would be that anytime you show up to be cared for, you will be treated regardless of whether you have insurance or you don't have insurance.
Okay.
And I take care of whoever comes through the door.
Yeah. Okay.
I honestly don't even know how to look that up in the computer system.
Yeah, I
don't want to know.
I just heard, since there's all these insurance things, that there's certain insurance provider that would only go to Kennewick or whatever.
Yeah.
But my other question is asthmatic. I'm asthmatic, and I have several people that I know that died from heart attack, and I know for a fact that they asked me the day before they died. They said, I'm having some asthma problem. And then the next day they died. And the cause of their death is heart attack. And I know that they use those spray. Those sprays are pretty bad. They're adrenaline. And so when those asthmatic people start having problem breathing, they puff that. And of course, what happens to your heart when you puff that?
It goes faster.
It goes faster, and that's when you get caused heart attack. So if you have asthma, be careful. Thank you.
Yeah, with asthma, certainly the symptoms of a heart attack include shortness of breath and chest pain, one symptoms of asthma. So I don't know that I would say the inhalers are causing people to have lots of heart attacks, although certainly stimulation to the heart when it's under stress is not great. But a lot of times it's mistaken. And what do we go to? If we've had asthma, we treat it. Hilda talked about that herself. Oh, it must be my asthma. It must be because we don't want to think we're having a heart attack. Mm-hmm. And so it may not be that the asthma is causing it, or that it's just we tend to think, oh, it must be my asthma, because that's what I've had before, and that's a little bit easier for me to deal with than thinking I'm having a heart attack.
Well, and one thing I would add, as a provider and actually somebody who suffers from asthma herself, is the story that Hilda tells about, wow, this was a little bit difficult to tell if this was my asthma or something else. Yeah, you kind of know. She kind of knew. She knew something wasn't right. She kept saying that. Something isn't right. When you've been an asthmatic, it's highly probable that, at age 50 or 60, you've had asthma for a while. This isn't a new thing for you. And I think one of the comments that she made that I have heard often in patients is that I don't feel good. Something doesn't feel right. I'm really fatigued. This is really hard. Asthma is going to be more about your breathing. So I think that's the little pearl that I would pass along regarding to that.
Question over here.
Yes, we always talk about the arteries being clogged, but we also have a lot of veins that are part of our heart as well. So I was wondering, can the veins and a clog in them create problems, or how do the veins around the heart as well as the arteries relate to us having heart problems?
Well, we don't have specific tests for the veins per se in the heart, but it's not an implication when it comes to heart attacks, because the arteries are charged with supplying blood that is oxygenated to the tissue, and if the tissue doesn't get the oxygen, that's in part how heart attacks would manifest. As far as the veins are charged with taking blood away from the heart to the somewhere else, like a vein in your leg would take blood from your foot back to your upper body, whereas an artery would take blood down to your foot to feed the muscles. So we don't have specific tests for veins, and frankly, we don't seem to get into too much trouble with not having tests for veins within the heart.
I just wanted to ask the question, what is the difference between having the angina attacks and versus heart attack? How do you really tell the difference? I have angina, so I am always confused. Should I call an ambulance or not? How do you go about finding? We're just new in the area and trying to find a cardiologist taking new patients versus, now we just keep driving to Olympia because we don't know how really to go about finding a doctor.
Ma'am, you see that little packet that you got? There is a nice list of not only cardiologists, but a wide array. Pardon me?
It's taking new patients?
Absolutely. Absolutely. Take your pick.
And your question about angina or angina, that is a descriptive term for chest pain, and we use it to refer to heart-related chest pain, but it's a symptom. So if you've been told you have angina, the key is it changing? If it's your everyday normal, no different than it was a week ago, a month ago, 3 years ago, then that's your stable pattern. But if it starts to happen more frequently, if it's happening with less activity, it used to be, if it didn't happen until I went up a flight of stairs and then I'd get it, but it always gets it. But now I just get up and I walk to the bathroom and I get it. That's a change. That's worsening. That's when it becomes what we call unstable angina. Or if it's happening at rest, that's now a change. Just like we've talked about. You know yourself, you know your body, you know your disease. Something isn't quite right, something's different. That's when you want to get it checked out. So angina is not as much a diagnosis, but is a symptom But if it's changing and increasing or happening with less activity, less exercise, you need to get that checked out.
Or if you find yourself needing more nitroglycerin on a regular basis. Welcome to the Tri-Cities. And I don't think we'll have any trouble finding you a cardiologist who takes new patients.
Nick, you were way over in the corner. That's about 20 steps.
You can have an M&M.
This isn't a question, but just an observation. It seems like we're worried about our insurance, which we should be, and we're worried about this, and we're worried about our students. But the message I keep hearing is, don't take chances. Check it out. And if I don't get anything else from this seminar, that's what I'm getting. And I think we all need to go home with that. If you're not sure, don't try to just say, oh, it's nothing. Get it checked out. And if it happens once and it was okay and you don't think you should go the second time, guess what? Check it out.
Yeah, I thank you for reiterating that. I tell people I would rather have you come in and find out it's nothing than stay home and have it be something serious. I understand. I have a family with 5 kids. I have insurance. It's not great insurance. I have a big deductible. I understand on that side of things too. But if you die from a heart attack, or if you're severely disabled because of the heart attack, that's a lot worse. And I'm very sympathetic to the insurance costs and the other things and all those, but tell people, gee, if I spend the night in the hospital to get this test, all these other things aren't going to happen, and all these things that are depending on me. Well, if they're depending on you that much, you're not doing it, and you're dying or being severely disabled. You're not going to be able to help them, and it's going to be a lot worse. So,
we have time for one more question. And I'm sure afterwards you can come up and cajole these fine speakers that we've had today. Yes, ma'am.
I really don't have questions, I don't think, but my heart doctor's insurance was canceled because he's a doctor. So there's insurance trouble for us. I'd like to thank the paramedics in Richland. They're wonderful. I think they should stand up. Everybody should applaud for them. Up, 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 up. And sort of a personal question. I read somewhere on the aspirin thing, if you're having a stroke, don't take aspirin if you think you're having a stroke, because it could increase a brain bleed. So there's a huge difference between hearts and strokes, I know, but is there any comment about that at all?
There are 2 kinds of strokes. Well, we'll simplify things. 2 kinds of strokes where you can have a blockage of the blood vessel, which is really the same disease as coronary artery disease, just in a different organ in the brain. But you're right, there are strokes that involve bleeding, where you can bleed. And what we do when you come into the emergency departments, and we think you're having a stroke, we'll get a CAT scan, and when we can see that there's no bleeding, we then give you an aspirin. It has not been, there is benefit, it has not been proven as beneficial in the stroke as it has been clearly shown in heart disease. Still, most of your strokes are going to be the occlusive, the blockage type. But when in doubt, you can hold off. I haven't heard strict guidelines do or don't, but we usually wait till we get the CAT scan before giving it in the stroke. But
well, before we do some drawings, I just want a round of applause for our speakers for sharing their time today with us. And they may hang around for a few minutes afterwards if you have some personal questions that you'd like to ask them that you didn't want to share with our TV audience and all us here as well. Again, we hope you enjoyed and got a lot out of this afternoon's presentation. We hope you have a wonderful Valentine's Day. Before we adjourn, I would like to thank members of our team that were responsible for making this happen. A round of applause for Emily and Nan and Stephanie and Nikki and Danica and all of our colleagues from Kadlec who played such a wonderful role in making this event happen. Thank you for joining us today. Happy Valentine's Day, and remember to be an advocate. Have a great day. Thank you.